Today, I am bringing on Austin Walters from Springtide Ventures. Before we get started with our just broader discussion about healthcare and about how healthcare costs are so high and what drives that, can you please tell us a little about yourself and what you're doing at Springtide?
Yeah, happy to, Nick, and thanks for having me on today. I'm a serial entrepreneur by background. I was an early employee or a founder at a few ventures prior to Springtide, including two media companies, Wim and Friendemic, and two health tech companies, Econos and Etalytics. Econos and Etalytics are in the ultrasound and precision genome editing analytics spaces, respectively. I founded Springtide in 2018 with the purpose of funding early stage healthcare innovation. Prior to or alongside of my entrepreneurial activity, I was a strategy consultant for some years at a firm in Boston called InnoSight. InnoSight was co-founded by a Harvard Business School professor named Clay Christensen, who was well known for developing the theory of disruptive innovation. And while working at InnoSight, I had a number of large healthcare clients. So I had experience in the industry from that perspective. And our purpose at Springtide is to fund disruptive innovation in healthcare.
And speaking of disruptive innovation in healthcare, why has healthcare been so resistant to disruptions that would make it more efficient and lower costs?
I think there are a lot of reasons. I think many of them could be bucketed under the category of skewed incentives due to how healthcare is paid for. Clay wrote a book co-authored with Jerome Grossman called The Innovator's Prescription some time ago. And in the book, there's a section on healthcare payment. And I think they make the comment that the way Center for Medicaid Medicare Services, CMS, develops reimbursement codes for healthcare procedures. And I might even have a copy of the book here. Yep. So this is from 2017. It's the last copy I had, but you can see even then, it's a pretty thick book, and every year the book grows in thickness. And it's because, just to take a random page, you can see, right, there are codes associated with every single procedure known to man in healthcare. And those codes determine what CMS will reimburse you for Medicare, Medicaid patients that are covered under one of those two government insurance programs. All of the large healthcare insurance companies benchmark to the same CPT codes. So they don't offer the same exact reimbursement, and reimbursement can vary from state to state and provider to provider, and they're negotiated, but they're benchmarked. Okay, so within a narrow band, the CMS is basically a market maker for how healthcare is paid for, right? It underwrites almost all healthcare. That system of payment is known as fee for service. And Clay and Dr. Grossman make the point that this is the only part of the U.S. economy that functions like the Soviet Union, where the Soviet Union economy depended on brilliant economists developing very complex algorithms for what the price of everything should be in a given year, right? 1972, here's what a ball bearing is going to be priced at from Moscow to Mongolia, right? And of course, no matter how brilliant the economists were, the real world is far more dynamic, and you have so many more variables in the real world that might determine demand for something in a given place and a given time. And so, the market is this dynamic thing that balances between supply and demand. Because of how healthcare is paid for, you have basically an entity saying, here's what the price of this will be, the price of this will be, and so on. So it's not a true market in that sense. And there are other reasons, Nick, but I'll stop for a breath there, because I think many of the reasons and just the nature of healthcare as a regulated industry, we've talked about how its pricing is regulated. There are other aspects that are also highly regulated.
Yeah, the most indicting regulation I've seen in the Obamacare legislation about this was the fact that health insurers, and let me know if I'm wrong on this, but I think it's that they have to spend a minimum of 85% of their top line in payouts.
Yeah.
And so if you are a health insurance company, you want to grow your profits, but you're a fixed gross margin, the only way that you can grow is by increasing your top line. And the only way you can increase your top line is especially if the population not growing that fast in the United States, is by increasing your prices. Even if you pay out more at the bottom end, you can grow it's 15% of $1 billion is more than 15% of $800 million. I think that's probably the biggest driver of like the post 2010 health insurance premium increases. But what are some other primary drivers of why healthcare costs are so high? Like in other countries, even with, I'd say arguably even more inefficient socialized medicine, they don't have their healthcare as more than 10% of GDP. So why is it close to say 18 to 20% in the United States?
Yeah, again, very, very complex problem. I believe the fastest growing branch of economics is healthcare economics, and has been for a decade or so. So lots of people trying to wrap their heads around why is this happening and how can we fix it. More importantly, I'll point to two areas of causality that I think are very relevant. One is just the demographics of the United States and the history of the United States being one, and then the other being just the politics and the policy, again, the regulation of how healthcare is paid for. So I'm going to come back to that with respect to healthcare innovation, actually, and talk about that. So the demographics of the United States. So you'll see comparisons between other post-industrial societies like Australia, South Africa, Europe, Western European countries, and the United States, Canada, and often that we're benchmarked to other post-industrial societies in terms of health outcomes and healthcare spend, right? Most of those healthcare systems are, and I'm going to come back to this point in a moment, but they're single payer for the most part. Some exceptions to that, but we are not exactly a single payer system, even though CMS sort of sets prices. We're not a single payer system, but our demographics are very different. The United States is basically a reflection of global demographics to some extent. We have it's a country that takes in people from all over the world, and it's as a result, very diverse society. So just the statistics of that and the inequality that exists in the United States, the different patterns of settlement, the fact that it's still quite a rural country, actually, and that healthcare access is a real issue. I think much of this is geopolitical, historical, and demographic in nature. So we can't forget that, right? That we don't have a society that's homogenous in the same way that Sweden is homogenous, right? And now if you carve out parts of the United States, like Utah, for example, it looks pretty similar to, say, the Nordics in terms of healthcare spend and outcomes. So again, much of it has to do with I think the diversity of our society, which I don't think any of us would want to give up. The other part, though, is more policy related and the nature of the U.S. economy. And And there are trade-offs with this, right? So broadly characterizing the US healthcare system as still being somewhat market-based, even though we have this kind of state underwritten payment system, versus socialized medicine systems like most European countries where you have a single payer. The benefit of the single payer systems is the collective bargaining power that they can bring to bear in determining what they're going to pay for, say, Ozempic, right? A new weight loss drug, or insulin as a diabetes therapeutic, and so on and so forth. Prices that are paid for drugs and devices and procedures in single payer socialized medicine systems are orders of magnitude less than what we pay for in the United States. It has to do with the collective bargaining power. It also has to do with the fact that in the United States, we have chosen to support and reward innovation. It's not always inexpensive to do that. We have an economy that is incredibly productive of innovation, which is great, creates jobs, particularly in innovation, call it hotbeds of innovation, sub-economies within the United States. So places like Boston, the Bay Area, right, and many other regions of the United States. There's really no other place in the world quite like the United States. Now, the trade-off is, though, that we are effectively subsidizing healthcare innovation for the rest of the world by choosing to, by paying the makers of these new weight loss medications in the way that we are paying them. And a lot of that goes back to these reimbursement codes, and much of this is politicized. Actually, it's not objective. It's a fair bit of it is the result of lobbying and influence and pork legislation and so on and so forth. So in politics, as you know, there's a ratchet effect, right? It's much easier to kind of move things in one direction, which is the direction of benefit, and much more difficult to kind of reverse that. So I think because of our system, we produce an incredible amount of innovation. The globe benefits from this in very significant ways. We don't face the rationing of healthcare in the same way that the single payer systems do, right? That's part of the trade-off. But as a percentage of GDP, we're closer to 18 to 20. So I think those are some of the principal reasons, at least, that, are top of mind for me as a non-healthcare economist.
Okay,